So perhaps the biggest changes in the guidelines are the suggestion that these newer antiplatelet agents can be used as alternatives to clopidogrel. The other changes to the guidelines include treatment times, where treatment times have been shortened. There's been a focus on shortening the treatment times for STEMI patients so that the first medical contact to balloon or device time should be less than 90 minutes. I think all of these changes in general are good for clinical practice. There have been some clinical trials that we discussed that really haven't made their way to clinical practice as yet, but in general, most of the new clinical trials have improved clinical practice and improved the outcome for patients. So the guidelines get updated every several years based on newer randomized clinical trials. And for practicing internal medicine physicians and cardiologists, it can be fairly difficult to read the guidelines because they're very long consensus papers. And so during our presentation, we try to summarize these relevant changes to the guidelines. Yeah, it's interesting. General cardiologists are more office-based now. And so I think the role they play in the inpatient management is a little bit less, and they're deferring to hospitalists or specialists such as cardiologists. In the clinical setting, some of the things we discussed for the management of acute coronary syndromes will be applicable, but the majority of things will be in the hospital setting. Yeah, there have been two relatively new agents that were only discussed in brief in the previous clinical guidelines, and these new agents are antiplatelet agents. One is Effient or prasugrel, and the other is ticagrelor or Belanta, and they're both very potent antiplatelet agents. They serve the same purpose, but their onset of action is quicker, they're more efficacious, and if you compare them to clopidogrel, in general they have improved efficacy, although they do have a slightly increased risk of bleeding. It can be difficult to balance that. On an individual patient basis, the risk for bleeding has to be assessed, and then the benefit for these newer, stronger agents has to be assessed. In the United States, perhaps 40%, maybe 45% of patients are being treated with these newer agents, and the rest are still being treated with clopidogrel, the older, more established agent. One of the issues with these newer agents, one is twice daily dosing, and they're both non-generic, so they both cost much more than clopidogrel. And clopidogrel now has a long track record in acute coronary syndrome, stable coronary disease, etc. So it's been around for so long that people are very comfortable with it. There are still ongoing clinical studies looking at these agents, looking at additional applications for them. I think right now the bottom line is they're being used in roughly half the patients. We're using prasugrel in our STEMI patients. We're using ticagrelor and prasugrel in some of our non-STEMI patients. And then for our stable coronary patients, because cost is an issue where I practice, we're still using clopidogrel. So the only other major area of the talk that we tried to focus on was what's referred to as STEMI mimickers. That is, conditions that appear to be a STEMI but in fact are not, such as acute aortic syndromes, pulmonary embolism, Takotsubo, cardiomyopathy, or broken heart syndrome, aortic stenosis, and hypertrophic cardiomyopathy. So there's certain things on physical examination, there's certain things on the EKG, and there's certain things about how patients present to differentiate them. But it can be difficult when you're encountered with a patient that's presenting with chest pain to make the distinction between a true acute coronary syndrome and one of these STEMI mimickers. For most of these patients, an electrocardiogram is done, a chest x-ray is done, laboratory studies are done, and then for the vast majority of patients, a consultation needs to be obtained with cardiology. I think some of it depends on the setting that the people are working in. There are some general practitioners that basically work as emergency room physicians and triage all the patients. So I think it depends a lot on your practice setting. Some general practitioners that have a lot of experience in the emergency room settings are very comfortable with these distinctions. The ongoing clinical trials will explore these newer antiplatelet agents. They will explore the role of PCI versus bypass surgery. They're going to explore the role of additional adjunctive medications that, as yet, have not provided a clear, consistent clinical benefit.